Hello and welcome to the second edition of the Mini Battle series. My name is Manos Brilakis from Hygeia Hospital of Athens, Greece, and this is the episode 15 since we count down to the February of 2020, then when we hope to organize live the next Athens Shoulder course. Until then, we came up with the idea of launching these monthly webinars dedicated to shoulder pathology and treatment in order to promote the contact between us, as well as the need for continuing education. So this is the Mini Battle series, and in this episode we discuss about the reverse shoulder arthroplasty, and more specifically for the patient selection and the technical application to arms for a successful outcome. So please take a moment to vote our first question, our first poll, which is in your screen in a little bit. According to your experience, which is more important for a successful reverse shoulder arthroplasty? Is the patient selection or the technique applied? Can we have the poll in our screens, please?
See.
Okay. Take your moment because we need some time for the question. Until everyone to take the chance to vote, so please, I would like to introduce Dr. Antonogiannakis to do the introduction.
So let me welcome you as well to the Mini Battle E-Series. I am Manos Antonogiannakis. I'm the chairman of the Athens Shoulder course. And so we decided with Manos Brilakis every month till February 2022, when it's going to be the 5th Athens Shoulder course, to have two charismatic surgeons, two shoulder experts to discuss, debate, present their views on a specific issue of shoulder surgery. And for this episode, today, we have two exquisite surgeons, two shoulder specialists, Professor David Dines from the Hospital of Special Surgery, Professor of Orthopedic Surgery at the Vail Cornell Medical College, and the past president of the American Shoulder and Elbow Society. And Dr. Alexandre Laedermann, Privat Docent at the University of Geneva, CEO of BMed. BMed is the host of this event, and we thank him for this. President of the Swiss Shoulder Society and president of FOR, the Foundation for Teaching of Orthopedics, Trauma and Sports Medicine, and also president of the membership committee of the European Shoulder and Elbow Society, and member of the Central Committee of French of the French Arthroscopic Society. So thank you, Dr. Dines and Dr. Laedermann, for accepting the invitation, and we hope that we are going to have a very nice discussion today.
So I would like to remember you that throughout the mini battle, you can submit your questions, and you can check if some question has been submitted by another colleague, and click on it in order to put it in the highest order. And before we proceed, we would like to see the results of the poll, if we can have them.
So we can start now with the first presenter, Professor Dines, we are going to discuss about the criteria for selection of patients for a successful outcome after reverse shoulder arthroplasty. Yes.
Okay, good. So it's my honor to be here, although I wish I was there. But in next year, in 2022, I hope to see you all in person. But this will have to do. My charge today is to talk about predictors of patient satisfaction after reverse shoulder. And this is going to segue into Alexandre's talk about the current concepts, really literally, of reverse shoulder. These are my disclosures, and none really relate too much to this particular talk. Now, there are a number of factors affecting outcome and, of course, then satisfaction in reverse shoulder arthroplasty. The reported satisfaction ranges in multiple studies from 58 to 94%.
Can you, sorry, Dr. Dines, can you share your screen because we can see your screen?
I'm sorry. I thought it was shared. Okay, let me go back.
Okay.
I'm going to escape here. Okay. Okay. I'm going to put this. I apologize. Just.
Does it account for the button?
Okay. Well, I'm going to put. Yeah.
The share screen.
It counts. It counts. I think I'm being handcuffed here. Okay. So can you see my screen now? I can't come up with where the. Oh gosh, this is crazy. Okay. I apologize. Let me click over here. It says I'm on.
No problem. Take your time. There's no problem.
Okay. Okay. Now I'm with you. I'm going to go share screen.
Yes.
And I'm sharing.
Perfect.
Can you see that now?
Yes.
Yes.
Okay. I'm going in honor of what Alexandre just said. I'm not going to redo what I just said. My disclosures are this. Here we go. Okay. So, but now it won't let me go ahead. Oh, what is this? Okay. You are share screening. I got to figure out how I can make my slides continue, and they're not. So let's see. Let me see if I can down here. Here we go. No. Okay, here we go. Okay, I think we got it now. Okay, so the reported satisfaction after reverse ranges from anywhere near 60% to 94%, but there have been very few reports on factors that influence post-operative patient satisfaction. In general, in joint arthroplasty, there are many factors that come into satisfaction, and that include extrinsic factors such as diagnosis, the amount of pathophysiology, the procedure itself, and all the accoutrements of that operation, including anesthesia, implant type, post-op rehabilitation. But there are also a number of intrinsic factors that we really need to evaluate in our patients so we can give the right expectation for them. And these include, obviously, age and gender, personality, expectations, activity, but also the physical and psychological comorbidities, which might affect outcome. And of course, specific diagnosis and disease severity also are inclusive. Now, the ideal patient for reverse shoulder, clearly, and probably why the operation was invented in the first place, is patients with cuff tear arthropathy. These are patients with massive cuff tears, and then severe arthritis. They have poor preoperative function, and in many cases, pseudoparalysis or even escape and instability. And these were very, very difficult problems to deal with in the past. Obviously, with the age and the advent of reverse shoulder, we have a much better weapon against these very difficult problems. But since then, the indications for reverse have expanded tremendously, not only for cuff tear arthropathy, but for patients with irreparable rotator cuff tears, with no arthritis, in some cases in the elderly, osteoarthritis with a thin cuff, osteoarthritis in more elderly patients, certainly osteoarthritis in patients with significant bone loss, fractures, post-fractures, malunions, tumors, and of course revisions. And in some cases, because some people think it's easier, I don't aspire to that. And we can now predict better outcomes. We know more about the pathophysiology. We have better technology, better materials, better diagnostics, and better understanding. And Alexandre is going to have the privilege of talking about all these things in the next half of this battle, which is really not a battle at all. So now we do have better imaging and surgical planning tools and guides and augments and patient-specific implants to really deal with the most difficult cases, especially those involving bone loss of the humerus or the glenoid. In a recent article by one of our former fellows, Brian Growdy, they looked at a systemic review of 47 studies with distinct diagnoses, and they concluded that the reverse shoulder is a reliable in all cases for improvements, but it was less so in trauma and revision shoulders. And this really told us basically that there were significant difference in outcomes that are based on the preoperative diagnosis and certainly the pathologic anatomy that we have to deal with. That being said, and this is a case in point, this is a person whose end result, if you will, on a patient reported outcome measure of the ASES of 62, who's really happy. Here's a 59-year-old person, infected total shoulder, unfortunately actually infected twice, had a spacer implant, and developed massive glenoid bone loss with cavitary lesions. This patient was indicated ultimately after correction of with antibiotics and appropriate treatment for a patient-specific implant, a VRS, as we call it, the vault reconstruction system. Post-operatively, here's his numbers: 110 degrees of abduction, 95, with minimal pain. Compared to what he was, he's incredibly satisfied. And even though his score is 62, as we'll say later, and not so Greek, this is a good delta. And we'll talk about that in a second. So patients who really obviously are not, you can expect won't do well. That's going to be patients with axillary nerve injury, deltoid incompetence, acromial or scapular spine fractures. These are tough, specifically the scapular spine fractures. Frequent falls, again, patients who are at risk, you really have to be careful. Active infection, clearly a contraindication, or certainly patients you expect not to do well. And here you get into the other group, the chronic pain group. These are people with psychological issues that are going to affect outcome. And of course, secondary gain. I don't know how much of this you see in Europe, but here in the United States with workman's compensation and labor laws, it can be a good reason not to have to go back to work if you're not having a good operation. And of course, there are many other issues. So what are the most common patient groups that won't do well? Well, we see this as a second group. And this to me is something that really where the rubber meets the road in this group of patients. And that are patients with good preoperative function. Be very leery of these patients. Patients with really significant and impressive external rotation lag. Another group we're going to talk about because these can be very, very difficult and challenging patients. And finally, the patients who probably don't need the operation in the first place. Patients who have just a short course of disability after a fall, and we'll talk about this as well, because these are patients you want to avoid so that you do get the right satisfaction. Good preoperative function, here we go. This looks terrible. Look at that colloidal shoulder from a cuff tear arthropathy. The problem is, this is what his range of motion is. So you've got to be really careful about doing a reverse in this person who really doesn't have much pain, but has a kind of a deformity and an unsightliness in his arm, but good function. Now, what is a good outcome following shoulder arthroplasty? This was a study done by Brian Warner from our institution, and we looked at basically the minimal clinical important differences for total shoulder and reverse in a ASE score was 9 points. However, the substantial clinical benefit score for reverse was 23 points on a shoulder and elbow score. Patients who failed to reach the minimum clinically important difference were patients who had higher baseline shoulder ASES scores, and basically patients who are reverse patients when you compared them to total shoulder patients. Now, what are the causes of poor post? Again, another study from our institution by Brian and our team, and this was what are the causes of postoperative improvement, of poor postoperative improvement after reverse shoulder arthroplasty. And if you see down here, the predictors were basically men, patients with more intact rotator cuffs, and a higher baseline ASES score. And when we looked at both groups, the final score was 72. But if you look here, the delta between the patients who had a higher baseline score and those who didn't was very significantly less. So you have to be very leery of patients who really, the improvement is not good enough to make them happy. And this experience has been shared by our colleagues from France. Gilles Walsh and Pascal Below have reported on this and discussed this with us numerous times. And if you look here, this is the one. Patients with better motion don't do as well and are not as happy. So we have to keep this in mind. The next take-home study, really from several studies, is that there's approximately 90% satisfaction in all patients. There's minimal to no pain, which is good. The validated shoulder scores are usually in the 70s, which is very reasonable, and range of motion is significantly improved, especially in those patients who had great disability before. But these are not normal shoulders. We're not making the shoulder normal again, and we have to keep that in mind. And we're going to address this more later in the talk when we talk about some of the psychological aspects. The implant is a constrained implant. It allows for stability, but we remember it limits certain motions, which can be very important in certain activities of higher performance, thereby having an effect on a patient's satisfaction as opposed to result. So there is a ceiling effect with reverse, and it tops out, as I said, at about 140 degrees with functional scores in the 70s. So we look at this reality outcome score minus expectations equaling satisfaction. This is an equation we came up with. And if we look at irreparable rotator cuff tears with bad arthritis and poor function, bingo, a home run in America. For you, it's just winning the World Cup in Europe. Now, if we have an irreparable rotator cuff tear with arthritis, but good function, this is a group that I would say you really want to have a long conversation and see what that patient's expectations are. Because even with an outstanding score result, they may not be as happy in terms of satisfaction. And certainly the other group, the irreparable cuff tear group with good function and no arthritis, I think you got to find another operation for those people to make them happy. Another group that I think it's critical to recognize and is very, very important in terms of outcome, and that's the patient who has substantial external rotation lag, or the so-called hornblower sign. And this has been defined well by Pascal Below as a combined loss of elevation and external rotation. And this is a very tough group. These are patients who have an external rotation lag, and they have basically a hornblower sign or an abduction lag. And when you look at their MRIs, they obviously have a lot of atrophy, specifically teres minor atrophy. This is a group you've got to be very leery of, both in terms of result and satisfaction. And Ryan Simovich, who's also now part of our faculty down in Florida, reported a number of years ago on patients with this particular syndrome, the impact of fatty infiltration of the teres minor on outcome of reverse. And what they found was patients with grade 3 or 4 fatty infiltration had worse constant scores, worse clinic patient reported outcome measures, less improvement, and less external rotation. They advocated, and others, of course, Pascal was the original one, of doing an internal latissimus dorsi transfer when you did reverse in these patients. Now, that's a good idea, and it would be reported by our good friend Christian Gerber in terms of result. And the outcomes can be good in certain cases. It depends on the severity of the atrophy and the weakness, but it is unpredictable. These are not clearly easy patients to deal with. Now, having talked more about the intrinsic factors, let's move into the other group of patients. And I think this is very important, the group of factors. These are patient variables, and they include things like age and gender, personality, and expectation. And of course, they include other physical and psychological comorbidities, which you have to factor in here, as well as the diagnosis and disease effect. Now, we recently published this. It's actually an e-publication in shoulder and elbow. Ryan Rauch did it for us. And we looked at, from our registry, 161 patients at a 2-year follow-up. We measured a number of their pre-op scores, as well as patient PROMs, patient-reported outcome measures, at 2-year follow-up. We also included short form 12s, both for mental and physical capabilities. And we looked at all patient variables. And this included age, sex, education, comorbidities, previous surgery, and expectation. And we also looked at a study at our own validated hospital for special surgery expectation survey, which is 19 questions to define what their expectations were. There are 5 satisfaction domains in this group: overall pain relief, overall function, pain relief, work activities, quality of life, with certain questions as whether they would do it again or not, whether they would recommend it. And what we can see grossly was that 71% were very satisfied. In the pain satisfaction area, 79% were, 60% only for work. In activities, the 47%, and we're going to talk about that in the next slide, and that has to do with biomechanics of a reverse, and certainly quality of life was certainly high on their satisfied list. 94% they would do it again and recommend others, and 60% wish they had done it earlier. Now, when we looked at these cohorts again, the lower satisfaction factors were patients who had higher expectations, specifically in work or sports activity, and more specifically, sports activity that involved, I'm going to go back, I apologize. Oh, hold on. I'm sorry, I jumped ahead with a little too fast on the draw. The group that really expected more out of the reverse in terms of sports activities, overhand activities, they were the least satisfied in many aspects. So if we also look at improvements, specifically improvements in patient reported outcomes, basically better outcomes had better satisfaction. I think that's obvious. Higher scores in VAS and ASES and SF12, especially those related to activity, had greater satisfaction. Unfortunately, oh my God, I'm sorry, this is very sensitive. Unfortunately, those patients who didn't do as well on the VAS for general health or the VAS for fatigue really correlated with less satisfaction. And this really indicated to us that preoperative mental or physical issues of health play an important role in patient satisfaction after reverse shoulder. So kind of the conclusions we had from this study were that in general, there's a high satisfaction after reverse. There's a high pre-op function. Patients who had high preoperative function were less satisfied. Higher demand expectations may not meet demand after reverse shoulder, and low baseline preoperative mental or physical health scores, they may improve, but they may still be less satisfied or more dissatisfied after reverse shoulder. Again, same as I just said here, low baseline, be careful, and there are certain people we should be concerned about. Those are with good preoperative function, and those patients with the hornblowers, much more unpredictable outcome. So what I would say, and my take-home message, in Greek, for all you people over there, is satisfaction after reverse shoulder. It's all about the delta. The bigger the delta, even if the scores are lower, the better they do. Meaning, you could start off with a much lower ASES score and not finish as high, but be much more satisfied because of the change. Expectation. They all want to hit like Tsitsipas, your very famous tennis player, but obviously they're not going to be able to. And we can't let them expect that they will have normal activity function. They will have good function, but it may not be as normal as they expect. And the other thing I caution about are patients who've had fractures, fractures that we treat with reverse. Milliseconds before they fell and broke their shoulder, in many cases, they had a normal shoulder. Even if you do the perfect reverse after fracture, they may not be quote unquote normal anymore because of the inherent restrictions of a reverse. And obviously, as I just said, recognition. Watch out for patients who are doing pretty well in terms of, as I said above, but more importantly, watch out for patients with big bone and muscle loss, the so-called clear patients we talked about, and those patients who obviously have psychological and medical comorbidities that you may feel will affect outcome. Thank you very much.
Thank
You
you,
all right?
Dr. Dines, for this, for the presentation and for all these remarks. And we will discuss later after Dr. Laedermann's presentation, because we see patients after INVEST that they are very satisfied and they have a very good result. And we can't find the difference between a normal shoulder and this shoulder. But this is not something that is predictable, at least till now. And what we are trying to see is what can make the prediction of a good outcome and a satisfied patient more clear. So, Dr. Laedermann.
Thank you. Thank you very much for this nice introduction. I would like to congratulate David because I think he did a great presentation and I completely agree with him. You need to know that I'm completely corrupted. I will try, however, to remain honest during this presentation. As you know, you're on DMED. There is on DMED wiki part. Almost everything that I'm going to say is on the wiki, so you can have a look. You can go back there. This is a participative website, so if you want to improve the website to yourself or to correct things, if you disagree, it's possible because it's exactly like Wikipedia. I think that when you plan a patient, of course, you need to take into account everything that has been said by David. And then if you plan a surgery, you need to have what we call a plan. And you need to remember that you can always amend a big plan, but you can never expand a little one. And this is a very important concept. First of all, when you go to OR, you will never do better than the plan. And when I am in OR, I am just a machine. I follow the plan, and if the plan A failed, I'm going to move to the plan B. And I hate surgeons that suddenly have a great idea in OR and change everything, because this is not the right way to do. You need to be prepared, and you need to have several plans in case of. Because bad thing can happen in OR, glenoid fracture, dislocate, a lot of bad things can happen. And this is just an example. This is one of my cases. I planned for this difficult case that doesn't have almost any more acromion and that has a huge superior and E2 fava glenoid bone loss. I plan to do a bio-assay. And actually, when I drill my human head, it just blew because it was only fat. So I didn't have any more proximal humerus. I moved to the iliac crest. It was exactly the same, only fat. So I finally had like a bad C-plan with a dry allograft, and this dry allograft with time failed. So this can happen to everybody. It happened to me, and probably that if I would have been more prepared, this would not have happened. You need to ask yourself if you need to change the stem in case of revision. Is there an adaptator if you don't need to change the stem to facilitate your life? How long do you want to go distally? All these little factors has to be planned before the surgery. Do you need to do contralateral X-ray or CT scan to plan the length of your humerus? I just remind you the study that we published in 2009. if you have a proximal bone loss, and if you don't restore humeral length, you have a high risk, really high risk of postoperative dislocation. So all this factor has to be planned before the surgery. There is the plan, and then there is the planning. And plans are actually, according to me, important, but planning is even more essential. Remember this. Planning, because all the patients are different. You need to be really precise when you implant a prosthesis, because some millimeters can do the difference. You need to have a very good implant bone sealing. You want to have for your patient the best range of motion possible. And very often, you need to choose the good compromise, because you will see there is not a perfect solution for a patient. They are only compromised. This is a study from Victor Dines. Actually, they proved that the 2D measurement was not so accurate. They compare planification with 2D CT and 2D planning, and what they observed that if you have 3D planning, it changes your version in at least 15% of the cases. It would change inclination in around 30% of cases, and even more important, the surgeon will change of implant in 40% of cases, meaning that if you don't do a good planification, in 40% of cases, you may not have the right prosthesis in OR. And this is a crucial factor. So planning is really, really important. We have now very good software that give you automatically the retroversion, the inclination, the human subluxation. So all these factors are becoming very easy to analyze. And they are important because, as I said previously, some millimeters make the difference. You need to be inferior with your base plate or to have an inferior eccentricity, because this will reduce the severity of scapular notching. This will also maximize your range of motion by increasing the subacromial space. Very important factor. You need to be quite close with your base plate to increase the subacromial space. Otherwise, as soon as you will do an abduction, the humerus will hit, will have an impingement with the acromion, and you won't have any more rotation. So try to increase the subacromial space. And then you see that some very little change can make a complete difference. Have a look to eccentricity. If you put your eccentricity inferior versus posterior inferior, you will dramatically increase the extension of your patient. And the extension is very important for internal rotation and in the back. From 52 degrees, you move to 53. So these little changes that you need to try when you do the planification may completely change the postoperative range of motion of your patient. So be very careful when you plan your surgery. If you use a smaller glenosphere, you will increase abduction at 90 degrees of abduction. External rotation at 90 degrees of abduction. So this is very nice, very, very good for small grandmother who wants to have a nice haircut. However, if you use a larger glenosphere, you will increase rotation elbow at the side and you will decrease the scapular notching. But you need to remember that larger glenosphere are more difficult to implant. This will limit abduction because you push the humerus under the acromion. You may have overstuffing and also increased polyethylene volume loss. So all these factors has to be taken into account. Exactly the same for curved stem. Everybody is looking at the humerus, but at the glenoid. But I think that the humerus is very important because you can play with the humerus. You can increase your lateral elevation by at least 7 millimeters compared to a Graham prosthesis. So it may improve the mechanics of the remaining rotator cuff and the deltoid musculature, but also, and this is a very important concept, it will compensate for medialization in case of bone loss. Just one example. The surgeon had a patient with a huge glenoid bone loss, and he had to have an access. He had to do an osteotomy of the carotid process because it was really an important medialization. And this surgeon only rely on glenoid reconstruction, and the long peg, even if it's a very long peg, doesn't even reach the native glenoid. So of course, this will fail. If the surgeon has do a good planification and realize that he could share the pain instead of using a straight stem, he could have used a curved stem. He will have shared the pain, do a smaller glenoid reconstruction, increase the lateralization with the stem, and he wouldn't have this kind of problem. So planification again is one of the key, because remember the difference between a straight stem and a curved stem, it's at least 7 millimeters. So this is a very important factor. So planning makes sense. To me, you spend 10 minutes in front of your computer, you introduce UCD, you do your planification, you have a 3D visualization, you have all the measures that are done for you. You play with virtual implantation. I know it's a pain because there are a lot of factors, but try to find the best one for your patient. Then you create a guide. You just send, you ask for the guide, and something like 2 weeks before you have a guide. And we had some problem at the beginning with guides that were done in plastic. It's not anymore the case. Now it's metallic guides that are stiffer and definitely precise. So this is a very nice way to have your central pin wire at the perfect position since the beginning. So this is an example. This patient, as you can see, has a severe superior bone loss. So this is a Fabin E2 glenoid bone loss. And then when I do my planification, I try to determine exactly where I'm going to put this red central wire. And you see that this is just above this small ridge of bone. So intraoperatively, this is exactly what I'm going to try to reproduce. You see the small ridge, you have this then huge upper erosion, you do small holes in the glenoid, you put your pin exactly where you want it. You can use a guide, of course, to do this. And then you take the human head of the patient, that you will feel this upper bone defect, you fix it with 1 or 2 screws, and then the game is over. Even if it's a very difficult glenoid, the game is over. You just put your base plate. I love to compensate the superior wear with a bone graft and a full wedge. So I do combine metallic and bony reconstruction. So this is the result after reaming. And then I use a screw base plate because I love the compression that it provides. So with a full wedge, I put my compensation in a posterior superior position. It's a screw base plate, so I will then add, of course, 4 other screws, but this just provides a terrific compression. And if I wouldn't have my preoperative pain, of course, I would have completely failed, missed the perfect position for the guide, and I would have completely missed the surgery. So planning is the key for these difficult cases. Then you put the glenosphere with an eccentric glenosphere, 2 millimeters. You try to put a curved stem, so you will compensate for lateralization, and this is the postoperative result. You reconstruct the superior glenoid, and you have a nice lateralization. Another case, this is a revision case. Where is my polyethylene? Do I have a bone loss? Actually, if I just look at this X-ray, I have absolutely, I will say, little idea. So this is what we have nowadays. We have very nice 3D reconstruction with the prosthesis. You can see the soft tissue, you can see the bone, you can see in transparency your prosthesis, so you know exactly where stop the previous prosthesis. I want to be 3 to 5 centimeters below the previous one, so everything can be planned. And then you try to put the prosthesis. So again, I will use in this case, a full wedge. And with this kind of software, you can remove the previous prosthesis, and you know exactly where you are with the actual one. You know how much graft do you need. You know where was your initial humeral prosthesis. You can put the new one. You can see if the stem is long enough, and so on and so on. And actually, you know where you are going. If you have this kind of information, little thing can happen in OR because you have a perfect plan. And then you mix everything. You see what does the joint look like, and you just reproduce it intraoperatively. And this is the post-operative X-ray, and actually I exactly reproduce what I plan pre-operatively. So we need, I think, to have a perfect planification if we want to have perfect results. But you need to know that all these things are great, but there are a lot of limitations you need to be aware of. And first of all, for bone planification, we don't know if it's truly accurate and if all the software agree. This is a paper that I published with Patrick Denard and Joshua Dines, and we looked at 63 consecutive cases. And interestingly, we compared two software, you know, and if you put the same CD in two software that will help you to plan your surgery, in 30% of the case, 30%. Why do we do planification? We do planification because we want to be precise at around 5 degrees. In 30% of the case, you have 5 degrees or more of difference of version between the software. And for the inclination, it's even worse. You have around 50% of the cases that has an inclination determined by the software of 5% or more. And this is around around 20% above 10 degrees. So this is very important. It's due to the technique, the method of calculation, of course. And the second thing is all this software, it's a suggestion, but propose to you to put everything at 0. The inclination, the retroversion, and I do not aim 0 anymore because I think that we need to find a compromise. And what happened when I tried to correct everything, I partially failed. Of course, I had probably better range of motion, but I also had more complication. And one of the dramatic complications that I had when I tried to put everything at 0 was a dramatic increased rate of scapular spine fracture. Because when you do lateralization and distalization at the same time, this is when you have scapular spine fracture. So lateralization alone is okay, distalization alone is okay, but with the software, with an only system, you combine this distalization and lateralization, and the results are not so great. Another problem is, do I have enough space for the guide? I'm using a sub-step-on technique, meaning that I try not to cut the subscapularis, not to touch the deltoid. I'm walking through the rotator interval, and you see that the space is really small. The space and I don't have enough space to introduce a guide. So for the moment, this is still freehand because I don't have yet better way to plan intraoperatively to guide my Kirchner wire. In the future, of course, with hollow lengths and so on, it's going to be better. But you need to realize that all these nice techniques are not always feasible simply because the guide is take a certain amount of space. And all this planification is great, but nobody's talk about the scapulothoracic joint, and the scapulothoracic joint is really important. What is the difference in your glenohumeral joint if you have an inclination of 5 degrees on the scapulothoracic joint and 15 degrees? This can be huge, and nobody is looking at it. So this is another factor you need to be aware of. And then there is a huge variability. Have a look at the dispersion of 10,000 of scapula. Everybody is completely different. So the planification is not the same for the scapula on the left and the scapula on the right. And these are two humans living today on Earth. It's not on one side a monkey and a human. It's both human, and they have a different anatomy that you need to take into account when you do planification. So there are clearly a lot of factors. And interestingly, for example, for abduction, if you play with lateralization, distalization, size of the glenosphere, it doesn't change a lot. This is a rather flat curve. It doesn't change a lot. Then have a look for adduction. It's completely, there is a drop, a huge drop. So for adduction, the implant that you will choose with your planification will completely change your postoperative range of motion. And then when you have a look to all the factors, it's becoming very difficult to find the right implant for the right patient. And I think that the solution, and this is not yet, it's coming, but without artificial intelligence, there are too many factors that we don't understand, too many prostheses, too many design, too many anatomy to choose the perfect implant for your patient. And we will need definitely artificial intelligence to work on this huge problem. And then another limitation of all this planification is the soft tissue planification that does not exist yet. First of all, a patient that had for her whole life 60 degrees of retroversion should not be corrected to 0. This patient should be maybe corrected to 30 degrees, to 20 degrees, but not to 0 because the correction is too much. She spent her whole life with these 60 degrees of retroversion. Then the planification, it's only a bone-based version, but some of my patients still have cartilage. What about cartilage-based version? We have no idea. There is a difference in volume with retroversion. Actually, we do not analyze this, and this is the muscle is another critical factor. It also depends on the tendon of the rotator cuff. If I have a patient that doesn't have rotator cuff, I want to have a medialization, so I increase the recruitment of the deltoid. If I still have a cuff, this is a complete other problem. I want to do a retensioning of the cuff, so I want a lateralization of the glenoid. So the cuff is important, and you need to analyze this preoperatively, and nowadays the software doesn't allow you to do this. In conclusion, you need to have a plan, but also a planning. PSI guides improve the accuracy. This is sure. Placing the initial guide compared to standard instrumentation alone or freehand surgery. And each of these systems has advantages and disadvantages. Big data and artificial intelligence will allow us to determine automatically the best option for each patient with specific anatomy and, I hope, soft tissue quality. And this will make our life easier and will improve definitely our clinical results. And you need to realize that we are not so bad. We move in 10 years from a rate of 20% of complication to nowadays something like 4 to 5% of complication. So it's not so bad, but of course the final aim is 0%. Thank you very much for your attention. This is of course the future, but as you say in David's presentation, the future is today because he's already using prosthesis that is adapted to the bone, and you don't adapt any bone anymore to the prosthesis. Thank you very much for your attention.
So thank you, Alex. And Manos, are there any questions?
Yes, thank you both for your outstanding presentations. And I would like to, before say the questions, the results for the first poll was 86% answer that they consider more important for a successful RSA patient selection, and 14% the technique applied. something that was I wait rather more technical preference from our audience. However, it was good that every one of us care about the patient selection. I have a question for Dr. Dines. I have a case recently with an os acromiale, and that patient have a lot of difficulties to raise her arm because she was a woman. And finally, he managed to do it, but after many months of physiotherapy. So I saw in one slide of your presentation that you referred that os acromiale, does this deformity affect the outcome? And if so, there is something that we can do to avoid this. Please unmute, please.
He doesn't want to fight again.
What is your till Dr. Dines unmute? Alexandre, Alex.
I'm here. I'm here.
Oh,
Okay,
welcome.
You raise a very, very difficult question. And it's not that I wanted to stop battling Alexandre. That's why I didn't go mute. I'm just technologically idiotic. But that being said, as you saw in my talk, again, the relative size of the os acromiale matters. There are different gradations, and a tiny little os acromiale probably has no effect. But if you have a person 50%, I think you have to be very leery of that person. And two considerations. One is basically I would avoid too much lateralization in that patient because I think it puts a lot of pressure on the deltoid and a lot of pressure on the pre-existing os acromiale. And if it's bad enough, I do think that you might actually have to consider fusing the os acromiale as part of the operation, although that adds a tremendous amount of kind of morbidity to the procedure. So in that case, I would approach it with trying to be less lateralized. And if that didn't work, prepare the person, and we might have to go back and do something about their os acromiale later. Difficult situation, no easy answer.
However, thank you.
Alex, what is your idea?
I completely agree with David. I do not lateralize. I just distalize in this patient. And if it's a pre-operative fatigue scapular spine fracture, and this happened, I fix them at the same time for the reasons. I have some examples. But if it's just an os acromiale, I don't fix.
Yeah.
Yeah. And about acromial fractures?
Excuse me. Yeah, I had this epidemic when I was distalizing, lateralizing, and using an onlay system. So I moved back to an inlay system to avoid combining these two programs at the same time. And now it's, I wouldn't say it's finished, but I have clearly less, around 2-3%.
My experience is that most acromial fractures heal by themselves, and the patient, after a few weeks of rest, gets back to pretty much normal, even though there may be deformity. I do use an onlay system in general. Well, I do. My system is a disclosure. My system is, as you most know, is an onlay system. And we really haven't seen acromial fractures in a percentage that makes it very significant. I think these are relatively rare. I think the real key and the ones you worry about are not the acromial fractures, but they're the spine, the scapular spine fractures, which are really difficult and can really have great morbidity for the patient.
So if I have a post-operative acromial or spine fracture that I want to fix, what I do is I use a tibial allograft and I fill the supraspinatus fossa with the tibia, and then I just create, so I cut my tibia and just create the support for the on the spine of the scapula that goes through the scapula, but through the allograft as well to improve the strength of the construct.
I think prevention is the best method of cure with those fractures. You talked about seeing it before, but what we've talked about more recently is the concept of the superior screw and being very, very careful where you guide that. Some systems, the guide goes 15 degrees north, and those, in some cases, if that screw's too long, you can create a stress riser in the neck of the scapula, and that can become a problem for you. So it's something to just consider in terms of all the other aspects that Alexandre talked about in terms of preoperative planning. I think the planning guides help with that and prevent us from getting into that trouble.
Yeah.
And Alexander, if you have a case that you should distalize and lateralize, what's your approach? What do you prefer to do? You have a rule about this, or it depends?
How you decide when to distalize and when to lateralize?
I would say exactly nowadays I try to lateralize. I try to lateralize 5 millimeters on the glenoid side, and I'm using a system that is between an inlay and a non-lay system. And I avoid to distalize too much because, as I showed, this increases dramatically the risk of postoperative neurological lesions. And this is in 45% of the case, the axillary nerve. So since I show this, I only distalize if I have a poor preparative acromion in order to decrease the stress in the acromion, and otherwise I just lateralize.
Basically, I really do similar, where we've come back to the same, where I guess we're all moving in the same direction because we've all been at this for a long time. But I agree with Alex on that less lateralization, certainly less distalization. But Alex, I would ask you a question. What happens when you have a person who has not as good a deltoid? Do you have what approach do you take in those patients where they might not have, there's some weakness to the deltoid?
Yeah. So we published a study about it in 2013 in the Journal of Joint and Bone. We divided the deltoid into, we did a classification with the rotator deltoid, the medial deltoid, and it was anterior,
Posterior,
medial, anterior medial, and then the whole deltoid. And we demonstrated that the patient that had a weak, complete deltoid had a poor postoperative function. So if it's only the anterior deltoid, no problem. If it's only the medial deltoid, for example, after a deltoid flap that has been done in the past, no problem. But if it's the whole deltoid, the results are not so good. So I mainly warn my patient. But and what you said is exactly the truth. If these patients are not doing well without a reverse, and these patients, they have nothing. And even if the result is not unbelievable postoperatively, there is such improvement for them that they are all happy. And you need to don't be afraid of, you need to have a deltoid, of course, but if you have a partial recovery and you already need to have an EMG, you need to test the strength of your deltoid. But if you have some deltoid, you can put a reverse and try to do lateralization and distalization, because again, distalization may create a double crush syndrome with a worsening of the axillary nerve lesion. So for this patient, I do lateralization only, I avoid distalization, and they are improving. It's not perfect, but they are really happy. So this is my philosophy.
Well, a high satisfaction rate for sure.
Yeah.
There are many questions for the participants. One of them is, what is the new in terms of the use of prosthesis in recurrent dislocation? What is your experience?
Lock dislocation. Go on, David, please.
No, I think that there's a good role for chronic. We're talking about more elderly people who've had chronic dislocations. We have a fair number. We actually published about 4 years ago as one of the cohorts in the article, and we've had very reasonable results in those patients with a reverse shoulder. And part of it is the implant design that you use. That article was written before we had much of the planning technology, and I think now in the face of some of the planning technology that we do have, and even some of the implant designs with augments and so forth, I think it's a very reasonable, very, very highly successful approach to a very complicated problem, for sure.
I agree with David. I will just add two things. The first one is, interestingly, most of the patients are doing well if you treat them conservatively. So there is not by definition an indication for surgery. And if there is an indication, you need to be really careful with glenoid bone loss, because the human head can create huge, really huge, massive anterior glenoid destruction. And this is quite difficult to reconstruct. So be very careful with pre-operative planification.
Right. Well, I totally agree with that, as I said. And now, even with implants that we have with augments and even patient-specific implants, that might be one of the places that those become indicated.
Yeah.
So, Alex, you use preoperative planning for all the cases, all your cases, or for the difficult ones?
No, I use preoperative planning for all my cases. However, I rarely order a guide, because I think that if you have a good plan, you don't do a lot of errors, because I'm using this famous subscribe on approach that does not allow me to use a guide, and because the guide is rather expensive. So the guide is only dedicated for complex cases.
So you do preoperative planning to all the patients, you use patient-specific guides in the difficult cases.
Yeah.
Rather, you are trying to able and repeat the plan that you had you made.
Yes.
We do the same. The last year now we have a system that allows to have a 3D reconstruction of the shoulder from the CT and do the preoperative planning on this system. And either we use patient-specific or navigation. And have you an experience with navigation? For
only observing others doing it. I have no experience myself at all.
I'm waiting.
Yeah.
I'm waiting.
Yeah.
It's supposed to come, but.
Okay, one question from Antonio Cartucho. What's the place of lateralized spheres in lateralization as opposite to bio-RSA?
I think I can take that.
Yes, David.
No, I would say this, that if you feel that you have to lateralize the glenoid, and that clearly there's an indication for that, I like to lateralize it using metal, not bone. I've gone away from any kind of bone graft unless it's absolutely mandatory and or accentuates an augment. There's the beautiful case that Alexandre showed us. I mean, in certain cases, you can't make it all up with metal unless it's a patient-specific implant. But in general, I opt for lateralization using the implant, whether it be with augments and or lateralization on the glenosphere, as opposed to a bio-RSA.
I do exactly the same. I mainly rely on metal, except if I have a huge bone loss, and then I do a combined reconstruction, metal plus bone.
Okay. One question is that does anyone do a less tuberosity osteotomy in his approach, and do you see increased complication or strength deficiencies?
I don't cut the subscap. I have a subscap, I do a subscap on technique, so I cannot answer.
So I didn't hear you. You say you don't fix the subscap, Alex? Is that what you said? Or?
No, I said that I never cut the subscap.
Oh, okay. So you do it right. You do it. So do you do a lateral approach? A lateral approach more than?
No, I always begin with a deltopectoral approach. And then, if I can confirm that the subscap is intact, I move superiorly, so I don't touch. I just push the deltoid posteriorly, and I'm walking through the rotator interval plus the supraspinatus that I cut.
Okay. Well, and I'll answer the question by saying I don't do an osteotomy ever, either in anatomic or reverse. That's a personal thing. But I do repair the subscap in certain cases if it looks to be viable. But in cases where it's been basically, if you will, trashed by the anatomy or just simply very, very poor, I won't fix it at all. I will fix it through bone holes in the humerus, but I don't like to take the lesser tuberosity because I think it compromises a reverse.
Especially if there is a problem with external rotation, then I try to avoid to repair the subscapularis because it's make even more difficult the external rotation. And using a bigger glenosphere, we use usually 40 millimeter glenosphere or 44. We didn't have an increase in dislocation when we did not repair the subscapularis. So the subscapularis is much, much more important for anatomic than
critical.
repairs. Yeah.
For an anatomic, it's critical. I know we're not talking about anatomics, but if you don't have a subscap in an anatomic, you better do a reverse.
The great advantage of the onlay prosthesis of David is that actually you don't destroy at all the tuberosities, because you just cut the human head and you never destroy the tuberosities. The problem of inlay technique is that with the reamer, even with the 36 diameter, usually you are very close to the tuberosities, and there is not any more bone for any healing of the tuberosity osteotomy. So I think that tuberosity osteotomy in a reverse, particularly if you do an inlay technique, is a nonsense.
I agree.
Alexandre, there's a question for you. Could you explain the effect on range of motion with glenosphere sizes, especially with 39 to 32?
Yeah. So 36 millimeters will improve abduction and external rotation at 90 degrees of abduction. Then if you use a larger glenosphere, you will increase your rotation elbow at side, and you will increase adduction. But you will decrease the abduction because if you have a larger glenosphere, the humerus will be pushed under the acromion when you move in abduction. So it really depends on the size of your patient and expectation of your patient. If your patient definitely wants to have abduction external rotation, you need to move to a smaller glenosphere. If he has other objective, you can, I think, safely use a 39 or 42. Again, it's dependent on the size of your patient.
Okay. We will agree that the outcomes for a reverse is different when it is addressed to fractures or osteoarthritis or rotator cuff arthropathy. Do you apply a different post-operative protocol when you do a reverse for a fracture or for the other cases?
Yes.
Okay.
Go on, David.
Well, I would say certainly for fractures, I want the greater tuberosity to heal. So I will treat them as I would have treated in the past a hemiarthroplasty for fracture, which is 3 to 4 weeks, where we basically don't do too much range of motion, perhaps some pendulums, and avoid active assistive or manipulative type range of motion until we get some healing. In terms of a regular reverse, I'm much more aggressive with letting them regain motion very quickly because I'm really not worried about repairing anything. I want to re-educate the muscle tendon units as quickly as we can to get the best possible result. So I'm much more aggressive with the non-fractures, but certainly slower with the fracture technology in reverse.
I do exactly the same. So my patient for primary cases, normal cases, they don't have a sling and they can move freely the day after the surgery. For fractures, I let them on an abduction pillow in abduction neutral rotation for 4 weeks to promote tuberosity healing. So I do the same.
See, we have a problem here. This was supposed to be a battle and we agree on everything.
Yeah, it's amazing.
There is a consensus, and this is very interesting also.
Okay, I have a provocative question for you, Dr. Dines. So if you want to battle. So
I don't want to.
You gave us some equations, some very, very good tips about the expectation concerning the preoperative patient situation. But which is your approach if you have a patient that you don't expect a very good result?
Well, I think that, I think we all wrestle with that because I think we all know that we have patients whose diagnosis, their pathologic anatomy is going to limit our ability to get the best possible result. I mean, and that doesn't happen very often. I would say, and I think Alexandre would agree with me, that in probably 95 or more percentage of the people we deal with, we're pretty confident that we can make their life significantly better. Now, what I think the mistake is to convince someone you're going to do a reverse and you're going to make them into something that they really can't be in terms of whether it be through activity. And I alluded to this in my talk, and that is expectation may be more important on the patient side than the actual anatomy or the procedure itself. And I think that those people, you really have to sit down with them and say, we're going to make you pain-free. We're going to give you a very good range of motion and function in life, but we're not going to make your golf score, your handicap go down necessarily. And we're not going to let you serve a tennis ball the way you used to. And I'm not saying that to be funny. I think that, we've come a long way. And as Alexandre alluded to before, the initial outlay or the initial foray, if you will, of reverse had 20 and 25% complication rates. Now they're minimal. We've really done a great job with all these things, but you can't expand that to tell a person you're going to create in every case a normal shoulder. So I know I didn't answer your question, but I sort of answered it.
Can I ask a question to David?
Sure.
Yeah.
Okay, David, in a study that we published in 2017, we showed that patients that were not doing perfectly well at 6 months were patients that had a poor preoperative perception of their upper limb. It's patients that could not elevate the arm, so they could not actually see in their daily life their arm. It was the contralateral arm that we usually neglect, and it was patients that have low simple shoulder value. So all these patients, who didn't have a very good perception of the upper limb. First question, have you observed this in your studies? And do you think that there is a role for this patient to preoperative physiotherapy in order to improve this perception?
The answer to your first one is I apologize for not being aware of it, but I certainly think it exists. I mean, there's no question. I probably have seen it. It's like being in the jungle and the tiger sees you, but you don't see it. And I would certainly agree that if I perceive that in a patient, that I think a preoperative course of physical therapy in terms of body sensitivity, not in just strengthening, but being aware, almost proprioceptive improvement. There's nothing wrong with that. And I think what it does is it lets you get to know the patient a little bit better. And I really mean that. It's almost like, it's like a bridge between the operation and So you have a better sense of what you're going to get when and if you do that patient, as opposed to doing it and they still have the same perception, and even with a pain-free shoulder, they still can't function. So I hope I answered your question, but I agree, and I'm going to look for it more for sure.
Perfect.
There is a discrepancy sometimes between the shoulder, the expectation of the surgeon and the expectation of the patient. And this becomes very clear, especially in fracture, especially in patients that they had a normal shoulder before the fracture. And we have a patient, he has a fracture, and then we do a hemi. And in my experience, the results were sometimes very good, sometimes very bad, but unpredictable. And then we start doing reverse for fractures. And then for us, the results became more predictable. Even if the tuberosities were not healed, still the result was better than a non-healed tuberosity in a hemi.
Right.
And for this reason, now we say to the patient, okay, we're going to do a reverse instead of the hemi. And we see the patient after the operation, and we comparing to the patients that we had a hemi, we say, oh, what a perfect result. But for the patient who didn't know what is a hemi and what is a reverse, and how was the patient before, what the problem of the patient was when we used hemi, he still has a bad result, or at least not so good result. And this difference in expectations between surgeons and patients is a big problem.
Well, I would agree 100% with that. And I think I alluded to it in my talk. The other issue is, and I think it's very, I mean, we're going back in time, we're changing the topic here a little bit, but I think that if you look at fracture, the best hemiarthroplasty with tuberosities that heal is the best result. Reverse, where a tuberosity heals, is the next best result. A reverse where the tuberosities don't heal is the next best result. And a hemi where they don't heal is the worst result. So that's how I would put them out there. That being said, we don't know which hemi is going to be the tuberosities healing. So we've really kind of gone to using reverse as a more consistent process. But I do believe that you really have to talk to patients with a reverse after fracture, because their expectation is they're going to be normal again. They don't know about, they didn't have 10 years of pseudoatrophy or 10 years of pain and disability. They had nothing. They were playing golf yesterday and they fell and broke their shoulder. So I do believe that's a very, very, an area where, like you said, patient expectation may be different than doctor expectation. And it's a good idea to put them together.
One question is, what is the percentage of metaclean seating that you still consider acceptable? Do you have a cutoff, Alexandre?
Yeah, I would say 95%. This is my aim. I don't, by definition, aim to have 100%, but 90 to 95, something that is reasonable for me.
I would kind of differ that a little bit, because I'm comfortable with about 80%. But of course, I would like 100%, let's be honest. But in those deformities where I can't completely correct it, if I'm off a little bit, if I get 80%, I'm with the porous ingrowth materials, central screw compression, and peripheral neutralization, I'm pretty comfortable with that.
Dr. Dines, in your experience, when do you expect the failures of the reverse?
When do you expect, well, excuse me, where do I expect the failures of a reverse to manifest?
The time that you expect a failure of a reverse.
He doesn't have.
Oh yeah,
doesn't
right.
exist.
I wish, from your mouth to God's ears, Alexandre. Yeah. No, but I think that there are different, when you think about it, the failure of reverse complications, they occur at different times. Clearly, things like, infection and stuff, who knows? I mean, God forbid it happens. It can happen at any time, early, late, usually late, not early. Things like acromial fractures can occur at the 3 to 6 month mark after a person starts using it more and more. So that's a group that you're going to deal with a little bit later. mechanical failure, I've got to be honest with you, and I think that Alexandre will say the same thing. He alluded to the fact that implants, preoperative planning, have really made this a much more predictable operation. So I truly believe that the complications in general are much less. And for that reason, they're going to be more out of the norm as opposed to in the norm. So I think you have to surveil your patients well. I think you have to watch them, especially in the first 3 months, see them a few times to make sure that they're doing the right thing and not doing too much of the right thing. The other problem I see, and I don't know if this might be an American thing, where if you make someone better, they then are determined to mess it up by doing too much too soon, and overusing the joint. Now, I don't know if that's a European issue. I'm sure it is to some degree, because to me, it's a human issue. But it's something you really have to sometimes kind of put the curb on people, check them down. And there are also other people that Alexandre alluded to before who need to be pushed up a little bit. So I think surveillance is important, but again, look for complications. Happily, they're less than they used to be.
We have extended our discussion, our time for discussion, but it was very interesting. And this time, I would like that it's time to vote for the second poll. And the question is, which option helps you more to achieve the optimal surgical outcome in a reverse shoulder arthroplasty? Pre-operative planning, PSI, or robotic or navigated surgery?
So, waiting
for
the poll. We started using pre-operative planning about 2.5 years ago. And at that time, the technician came and asked me, okay, now we have a 3D reconstruction of the joint. Where do you want to put the implant? And this was a difficult question to answer. Of course, there are some rules, but it was a compromise between how to medialize, how much contact you have, what retroversion is acceptable, what is the distalization that you want, and the lateralization also. And suddenly I realized that there were so many parameters that you had to take into consideration that at best you could have some compromise of what seemed more difficult, more acceptable. And it was much more difficult than to take a decision when you had an X-ray and you just put a two-dimension X-ray and said, okay, this is well implanted. And so I said, okay, let's take the patients that they had a very good result and see how we implanted it and see what we did, and so have some limits, acceptable limits. And then we saw that the mean was much different than what we expected that we were doing, first, and second, that the deviation was big. And this makes even more difficult now for us to decide what is the right implantation, or what is the right compromise of all those things that we have to take into consideration. Taking into account just the anatomy. If you take into account also the patient, the whole patient, then it's even more difficult.
Agreed.
I totally agree, and I think again we have to remember something, and that is when we put a reverse in a patient, we are creating a different, basically a different shoulder. It is not the shoulder he was born with, or in his normal time had, or she. So I think these are moving targets. When you remember, and I know some of the older people with me here will remember, the Grammont prosthesis, when it was invented, we put 20 degrees of retroversion on the stem and neutral glenoid. That's all we did. We didn't know any better. That was how it was prescribed. Now I think we do look for a more anatomic type reconstruction. Do we know why? I don't know that we know why. Alexandre's done some amazing work on different head sizes for different ranges of motion, and it's been done by others as well. So I think we're still in an evolving process, because I don't think there is one best. I think there might be something that's better for that group or that person, and less and better, something else is better for another person. Speaking of, kind of when we talk about preoperative planning of the bone, and now we're talking about preoperative planning of the soft tissue, I think we're melding this. And it may just be that we have to wait till we have artificial intelligence to get the perfect outcome.
Yeah.
Perfect. I would like to say that the next episode is on the 10th of December, and we will speak about SCR, and we will have Clara Azevedo to fight Anna Caterina Angelo. It will be very, very interesting. Two dynamic girls to fight each other, and we wait about this. And in this time, I would like to thank you very much about your presence here. You have an excellent talks. We have a very good discussion. We have a very, very nice very nice atmosphere for a battle. So I think the problem are the same, and we pretty much think about the same situation.
So,
thank you to all of you.
goodbye from me.
Thanks so much.
Thank you for your presentation. Hope to meet real and not virtual in Athens or anywhere else when our life again is going to become more normal than now. Thank you and good night.
Thank you.
The only thing I'd like to say
Thank you very much.
Thanks, Al.
Yeah.
David, see you in New York.
I hope so.
Soon.
Sooner than later. Okay, guys. Thank you.
I will come. Bye-bye.
Bye. I would like to say only thing that I would like from the participants to complete the tiny questionnaire in their screens in order to help us to improve. And thank you very much for attending. Bye-bye.
Bye-bye.